Looks like people are popping in. We had a little over 200 registrations. Um, Looks like I'm going to give it a couple more minutes to let people get in. Oh, that's interesting. So I'll go ahead and introduce myself. I'm Amanda Moore. I'm founder of Appendicure, and I am a caregiver to my husband David, who was diagnosed with appendix cancer in January of 24. We found Dr. Shen after he had a major surgery with an appendix cancer specialist. The recommendation after the surgery, once the pathology came back, it was 6 months of FOLFOX every 2 weeks, and it was a 50-50 chance of recurrence. And the explanation was really they treat it like colon cancer. This is 24. Um, that didn't sit well with us, so we went and got more opinions, and actually about five more opinions. And Dr. Shin was one of them, and he was the only person who could produce data that said, with our particular type of cancer, the stage, the pathology results, that it just did not make sense for our situation. So David is NED today, and hopefully will stay that way. I feel that we definitely dodged a bullet with 6 months of chemo that actually would not have helped either way in regards to a recurrence. So we are forever in debt to Dr. Shin, and thank you so much for joining us. Please introduce yourself, and I'll stay silent until we get to the question and answer point.
Okay, yeah, well, Samantha, thanks for the introduction. So I'm Dr. JP Shen. I'm now assistant professor at University of Texas MD Cancer Center. It's been, I guess, 7 years since I've been here, and I guess really 9 years since I've kind of begun specializing in appendix cancer, going back to my training at UC San Diego. So, appendix cancer is relatively uncommon. It's often called a rare tumor, but the incidence is increasing. There's probably now more than 5,000 new diagnoses a year in the United States, and it's been well documented that the rate of in which people are getting appendix cancer is much higher, which is unfortunate. Previously there wasn't really a whole lot known about it, mostly because people hadn't really taken the time to study it, and so that's really kind of been the focus of our lab. We so, um, our lab, I'm a physician, medical oncologist by training. So I kind of see patients and evaluate if they need chemotherapy, and if so, what is the best chemotherapy. Um, I've also kind of now got into designing and executing clinical trials. But most of my time is really spent as a scientist. So we run a full wet lab. So we take tumors from patients and grow them in mice, grow them in organoids, so we can test out new potential therapies. And then we also have a computational division. So we have people trained as computer scientists that help us analyze tumor genomic data. So what genes are expressed in the tumor, what genes are mutated, because it turns out that that's really important in predicting what drugs are going to work for each individual patient. So we're actually now, it's exciting times in 2026 where we now are kicking off a big effort to start using machine learning to help us do this, to help aggregate data. And so I think that the pace of drug development has been very slow in appendix cancer. There's not any FDA-approved drugs in appendix cancer currently, but we think that we're starting to speed that up. Um, so, for a long time, there was this kind of now, I think, outdated and debunked idea that appendix cancers are the same as colon cancer and should be treated the same. For a long time, the NCCN guidelines had the statement there that's crossed on the slides that you should, consider systemic therapy for colon cancer, for appendix cancer. Um, that's no longer the case now, although unfortunately the current version, which is like the first draft of the national guidelines for appendix cancer, really just kind of copied the colon cancer guidelines without a lot of thought, which is unfortunate. And so rather than directing people to the NCCN, which is kind of the standard for most tumor types, really, the surgeons have been leading the treatment of appendix cancer, kind of since its inception. And so these guidelines that are endorsed by the Society of Surgical Oncology, you can see the references there. It's just called the consensus guidelines for the management of appendiceal tumors. That's really the place you should look for guidance and direct your physician to read these guidelines, not necessarily the NCCN. It's called consensus because it was a group of I think somewhere between 120 to 140 physicians, all of whom see a lot of appendiceal cancer patients, and it went through multiple rounds of voting until the basically guidelines were agreed upon by everyone. So that's why it's called consensus. The people in this call probably know that relative to colon cancer, appendix cancer is much more indolent disease course. You can see that with well differentiated, also called grade 1 tumors. Many patients are alive at 10 years. In fact, majority of patients are alive at 10 years. And it's very different story for the grade 3 or poorly differentiated patients. Because the histology, basically what the tumor looks like under the microscope, is so critical. We encourage everyone to, if possible, get an expert pathologist to review their pathology. Unfortunately, a lot of times whenever we see a new patient at MD Anderson, we have our pathologist review basically the slides from wherever you had your surgery get sent to us, and we have a group of pathologists review that, and maybe as much as a third of the time, the diagnosis changed in a meaningful way. So it's very important to have someone who does this frequently evaluate the image under the microscope, because it changes not only what to expect in terms of how long you're going to live, but it also changes whether or not we think you're going to benefit from chemotherapy, etc. Don't want to get too much into the weeds of the molecular differences, but the reason that we think that appendix cancer needs different treatments than colon cancer, if you look at the mutations, the kind of the underlying genetic abnormalities that lead to cancer, appendix cancer is completely different than colon cancer. Essentially anywhere you look, whether you look at the DNA level, the genes that are mutated are different. If you look at the RNA level, the genes that are expressed is different. If you look at the microenvironment, like how the fibroblast immune cells and other non-tumor cells respond to tumor cells, is different. We did a big study where we looked at circulating tumor DNA. That's kind of the middle panel. So, most of the time, you're not going to be able to detect any circulating tumor DNA in appendix cancer. It's very different than colon cancer. You can see that it's on a log scale, but you can see there's less than 10 times as much tumor DNA detectable in the blood in appendix cancer versus colon cancer. There were some questions that submitted advance about goblet cell. We'll talk a little bit about this. Goblet cell is a really interesting tumor type, a subtype of 10 to 15% of appendix tumors are going to be called goblet cell, and that's based on how they look like under the microscope. I don't have a picture of the goblet cell, but essentially the goblet cell is the cell that you normally have in your intestine, and what they're supposed to do is they receive signals from your brain to release hormones to the other cells around them. So it's in a way kind of like a neuroendocrine cell, so a cell that receives information from the brain, secretes hormones, but it's also kind of like an intestinal cell that forms a barrier. And so these goblet cell tumors are kind of a hybrid of an endocrine tumor and a traditional epithelial intestinal tumor. But under at the molecular level, they're very different. And so we discovered this in collaboration with the company Natera, who generated the sequencing data that this gene called ZFP36L2, which is a zinc finger binding protein, is the most commonly mutated gene in goblet cell. And we've now in the lab used CRISPR to knock that gene out, and you can see that basically it makes the tumor cells grow faster. And so the next step will be to now that we've established these organoids, we'll start treating them with drugs. So we'll be able to see when we see this DFP36L2 mutation, what are the best drugs to use in that situation. So that's in progress, but not quite ready for prime time. Prime time meaning treating patients. And so it's relatively hard to do clinical trials in appendix cancer, but not impossible. And that's so we've really started doing this. As of now, I think there's only 8 prospective clinical trials in appendix cancer that have been run ever. 4 of those were done at MD Anderson. I guess completed and published. So in the published literature, there's really just 8. This is one of the 8. And so, anecdotally, we had seen a lot of patients with low-grade mucinous tumors get chemotherapy and not respond. And so we didn't think it was helping them. And so we wanted to do a trial to kind of prove that point. And so basically, this was what's called a crossover design, if you can see on the right side of the slide, meaning people either got 6 months of chemo and then they crossed over and they got 6 months of just observation, no treatment, or they got observation first and then they crossed over and they got 6 months of chemo. So everybody got 6 months of chemo, 6 months observation. The randomization was whether you started treatment first or not. And so the question was, can you safely delay treatment and still achieve the same outcome? And so so what we found is so not a single patient achieved a actual response. So to be called a response, you have to be below 30% like size of tumor. So there was not a single objective response. And if you look, kind of a timeline here, you can see this is the size of the tumor. During the observation periods, it's basically flat, and during the treatment periods, it's also basically flat. And so there's really no difference. There was no difference in the rate of tumor growth, whether you're getting 5-FU based chemotherapy or nothing. And so just to unfortunately, this didn't make it into the new NCCN guidelines, but the time to give someone with a low-grade mucinous tumor 5-FU is basically never. If you think if this was a developmental drug, if you did a phase 1 study and you had a response rate of 0, that drug would never be tried again in those patients ever, because the chance of it actually working is basically 0. And so based on this, we're now looking for other therapies because we know that again, this is specific for low-grade patients, low-grade mucinous tumors that 5-FU is ineffective. So one thing we looked at was a class of drugs called taxanes. Paclitaxel, docetaxel, cabazitaxel, these are all FDA-approved taxanes. Abraxane is a kind of special formulation of paclitaxel, which we've also used. These drugs work in esophageal cancer, gastric cancer, small bowel cancer, not in colon cancer, but we think colon cancer is really kind of the outlier in the intestinal tract. And so, again, because drugs like paclitaxel were tested and didn't work in colon cancer, people had not tried them previously in appendix cancer, but that didn't make a lot of sense to us, given that appendix cancer is arguably more similar to gastric cancer than it is to colon cancer. And so this was just a very small study of the first 13 patients that we treated with appendix cancer with taxanes. These patients had, many prior lines of chemotherapy. And despite that, we still saw 30% response rate, which is pretty good for patients who have had 3 and 4 lines of prior therapy. And so based on this, we routinely incorporate paclitaxel combinations in treatment of appendix cancer. So a lot of times we'll go with carboplatin, paclitaxel, but there are other combinations that we use. Moving on, this is kind of relative to the case that Amanda mentioned. For early, so just like a lot of physicians were using 5-FU treatment for appendix cancer because it worked in colon cancer. After people had surgery to remove an early stage, so it would be like stage 1, stage 2, or stage 3 appendix cancer, a lot of physicians were recommending chemotherapy. That's called adjuvant chemotherapy. That didn't seem to make a lot of sense to us, just because anecdotally we couldn't think of that many patients who had early stage appendix cancer who were actually relapsed. And so it didn't really seem like the chemotherapy was doing much. And so to study that, we now have a database where basically all of every time a patient sees us at MD Anderson, their data gets, moved from our electronic health record into a database, and we can now search that database. And so we were able to find, um, roughly 200 patients who had their surgery at MD Anderson, people with stage 1, 2, or 3 appendix cancer, and only 19 of those had relapsed. So the overall chance that your tumor would come back, any appendix cancer stage 1 through 3 is less than 10%. So that right there means that, if you treat all these people with chemotherapy, 90% of them, their tumor wasn't going to come back anyway. So either the chemotherapy is really, really good, or the risk of the tumor coming back is just pretty low. And it turns out that for the most part, the chance of relapse for most early stage appendiceal tumors is pretty low. You can see, goblet cells especially low, only 3%. Gets up to 17. Well, signet ring cell being the one exception, where the 30% of signet ring cell tumors recur. That's the one of the few times I would recommend using chemotherapy adjuvantly in appendix cancer. And then we kind of look to see, is the chemotherapy helping anyone? And so again, this is retrospective, meaning looking backwards, but you can see that if anything, the people that got adjuvant chemotherapy did worse than the people that didn't get adjuvant chemotherapy. We don't think the adjuvant chemotherapy is hurting people. This is just, higher risk people were getting chemo, and the chemo wasn't really doing anything. And so if we look only at the stage 2 patients, you can see that, absolutely no difference. Basically, if you have a stage 2 tumor and you get chemo, you're going to do great. If you got a stage 2 tumor and you don't have chemo, you're going to do great. Like 95% of these people are still alive at 6 years or 5 years, regardless of whether you get chemotherapy. And so, for this reason, except for very, very rare circumstances like a signet ring tumor or a really large number of positive lymph nodes, or you think that the tumor really is metastatic and it just wasn't seen on surgery, would not recommend adjuvant chemotherapy for early stage patients. And so this we presented this poster at ASCO GI just earlier this month in San Francisco, and the manuscript is in review, and it'll soon be posted to the preprint repository called medRxiv. So by next week, hopefully you'll be able to see this. There's a lot of challenging problems in the appendix cancer. One of which is that it's hard to have a quantitative measurement of the size of the tumor on imaging, and this is because in the peritoneal space, the tumors tend to, latch onto surfaces. They'll coat the surface of the intestine, they'll coat the surface of the liver. And so if you're looking at it, it's very obvious that there's tumor there, but it's hard to measure on a CT scan. And, measurement on a CT scan is the primary way in which we assess if drugs work. We need to call it a response. We have to get 30% smaller on a CT scan. And so we wanted to see if we could use blood measurements to help us, track tumors and predict. And it turns out that some appendiceal tumors will express CEA, some CA19-9, some CA125, some none of them, but most of the appendiceal tumors will express one of these 3 tumor markers. And it turns out that it is strongly prognostic that if you've got, no elevation in any of the tumor markers, your chance of being alive at 10 years is very good. Whereas if you have elevation, it's much less. And if you're in the very highly elevated, which is this light blue line, the survival is much worse. And that's true for both low grade and high grade tumors. So we use tumor markers quite a bit in terms of assessing how well chemos work, because CTs, there's not one perfect way to measure appendix cancer. CT scans are important, but the blood work is also important. And so I kind of mentioned this earlier when I talked about the goblet cell, but because it's challenging to do clinical trials in appendix cancer, like we're still doing them, but it is challenging. We're trying to learn as much as we can from all the patients who are not treated on trial. We're now up to just over 4,000 patients in our database. As an institution, we see upwards of 300 patients a year. And so aggregating this, we're getting a large enough cohort of patients to really be able to study. So this is why we can tell you that appendix cancer happens to significantly younger people versus colon cancer. 37% of the appendix cancer patients that we see are diagnosed under the age of 50. And unfortunately, if you look at over time, that's actually moving young. One of the things that we can get from these retrospective data is what is the best amongst the chemotherapy regimens that we're using, which one is best. And it does look like there's clear benefit to adding the VEGF antibody bevacizumab to frontline chemotherapy. I was taught by the faculty at UC San Diego that mucinous tumors are more likely to respond to irinotecan, and so I usually use FOLFIRI bevacizumab as the frontline. But we now have some data to suggest that FOLFIRI plus bevacizumab does do a little bit better than FOLFOX plus bevacizumab in the frontline. This is not a huge number of patients. It's only like 160 patients where we're trying to. The reason it's only 160 patients is this is most of the patients that we see at MD Anderson live not in Houston, Texas, but in Mississippi, Alabama, Georgia. People come from all over, and a lot of times we'll get the recommendation. You should get FOLFIRI plus bevacizumab in the front line, but they go back to home to get that, and so we're in the current standpoint, we don't capture that data very well, but we're working on doing that. We're actually using large language models to extract this information to a structured format. So we hope to be able to do this analysis on all 4,000 patients or nearly all 4,000 patients in the future to kind of give us more granularity about which of the patients that would do better with FOLFIRI, which of the patients that would do better with FOLFOX. Do all the patients benefit from bevacizumab or just a subset? So those are all questions that we're trying to answer. This is one area that we've been really excited about. So I just want to highlight this was not work that we did, but was led by Andy Lowy, who is a very well-known surgeon for appendiceal, also pancreatic cancer, and Shumei Kato is an old friend from UC San Diego who is a medical oncologist. And so based on a couple anecdotal cases of patients with GNAS mutant appendix cancer who responded well to the drug palbociclib, they did a whole case series of 16 patients. You can read the paper to get more details, but a very encouraging response rate. And so, given what we showed you about 5FU does not work in low-grade patients. So GNAS mutant tumors tend to be low-grade mucinous tumors. If I see a low-grade mucinous tumors, my frontline therapy is either the palbociclib or a similar molecule. There's also a drug called abemaciclib, which is very similar. Either one of those two would be my kind of first choice, or potentially immune therapy. Again, highlighting the fact that the pathology review is critical because this data is in low-grade patients. It's unclear if it would also apply to high-grade patients. I also think that these drugs, the CDK4/6 inhibitors, will be active in some GNAS wild-type tumors as long as they're P53 wild-type also. And we're working with Dr. Lowy and others to really test that hypothesis. Okay. So this is the test. So the other, I think, very exciting development in, especially low-grade tumors is this immune combination. So this was a study that we did here at MD Anderson and it was sponsored by Genentech. So atezolizumab is a PD-L1 inhibitor. PD-L1 is a negative signal in the T cell. So if you block the break of the T cell should be more active. More active T cells should recognize the tumor and kill it. Bevacizumab should change the microenvironment, normalize the vasculature, and we think act on the fibroblasts to hopefully get those activated T cells closer to the tumor. And this combination worked very well. And again, this study was mostly low-grade patients. So you can see 8 well-differentiated, so that'd be grade 1, 7 moderately differentiated, that's grade 2, only 1 poorly differentiated grade 3 tumor. This was not randomized, but we compared it to a historic control. And so, not surprisingly, these patients who all got 5FU chemo, which we know doesn't work, didn't do very well, but the ones on the trial did significantly better. And so this is our go-to really for most of our low-grade patients. We'd love to try combinations like higher order combinations. For example, there's no reason from a safety standpoint that you couldn't do the palbociclib plus atezo-bev It's really just kind of an insurance limitation, but we're trying to test that in preclinical models so that we can kind of test that in patients and ideally get a sponsorship for a clinical trial. I don't generally use the atezo-bev in high-grade tumors, just unfortunately they seem to grow a little bit too fast because this is a slow-acting regimen. But we'd be excited about trying the combination of chemo plus the immune therapy, which is kind of how gastric cancer is treated, or is how gastric cancer is treated right now. So we are currently in negotiation with the pharmaceutical industry to sponsor a trial like that. Okay. I definitely want to leave time for questions, and unfortunately, I've got a hard stop at 6. But immune therapy is there's a reason that the oncology community is really excited about immune therapy because when it works, it can work really well. With traditional chemotherapy, it's not a question of if the tumor is going to become resistant. They will all become resistant. It's just a question of when. It's maybe one in 10,000 tumors will be cured with just traditional chemo when it's metastatic. And so this is actually data from colon cancer. I know I spend most of my time telling you that colon cancer and appendix cancer are not the same, but we just presented this again at the same ASCO GI meeting in San Francisco. That if you take so on the left here you have colon cancer tumors that have liver metastasis. On the right you have colon cancer tumors without liver metastasis, and you can see that on the left, if you have liver metastasis, whether you get an immune regimen or just standard treatment, it's no difference, and outcomes are poor. Maybe 10% of patients are alive long term. On the right now, this is colon cancer patients without liver metastasis. And the reason that's relevant to appendix cancer is that liver metastasis is very rare in appendix cancer. Like less than 10%, maybe only 5% of patients with appendix cancer will get liver metastasis. So in most cases, the right curve is more like what appendix cancer is like. And so this gave us a lot more encouragement that we think that the tumor in the peritoneum or in the lungs, most of the time, appendix cancer stays in the peritoneum. Sometimes it will get into the lungs, almost never into the liver. Those tumors tend to respond. Those kind of anatomic sites have more immune surveillance and are more likely to respond to immune therapy. So if colon cancer, which is not traditionally thought to be a immune responsive tumor, we're seeing that the survival is meaningfully longer in patients who are getting immune therapy versus standard therapy. And, importantly, you can see that, almost 25% of the people who are getting immune regimen are alive 3 years later. This is people with metastatic, this is from the time of the third, so this is people who have already gotten FOLFOX and progressed, FOLFIRI and progressed, and now this is the third line treatment. And even 3 years from that, 25% of them are alive, which is pretty good. And so with this, this is an appendix cancer talk, but based on these data, I've changed my practice of colon cancer. So if I see a colon cancer patient without liver metastases or without liver metastases in the third line, I'm now using immune combinations, whatever. And for most of the time, we're getting insurance approval. I would say maybe 80% of the time, this is approved by insurance. And so we're using this. We're using this regorafenib plus ipi/nivo in a lot of colon cancer patients, and I'm actually, because atezo-bev didn't necessarily work so well in high-grade appendix cancer being more similar to colon cancer, I'm using the regorafenib, ipilimumab, nivolumab in appendix cancer as well. Okay, moving along, and so this slide here, immune therapy, when it works, is great. The big problem is that it's really hard to predict who's going to be the person that it works for and who is the person that it does nothing for. Right now, most of the time, there's really not a good biomarker for that. In lung cancer and head and neck cancer, you can look at this PD-1 expression or PD-L1 expression, but that's not very useful in colon cancer. We haven't looked that much in appendix cancer because we don't have enough data, but I don't think it's going to be very useful in appendix cancer either. The one thing that we are using now is what's called a tumor microenvironmental profile. And so this is data from a company called Boston Gene, but there are other companies that are starting to generate this now. An appendix cancer tumor, actually, most of the cells in that tumor are not tumor cells. You have a lot of macrophages, you have a lot of fibroblasts. Sometimes you have a lot of immune cells, sometimes you don't. But by doing RNA sequencing, you can actually get a profile of how is the body responding to the tumor cells. And we haven't proven this yet, but we think that when we see that there's more B and T cells, so T cells are the cells that are the kind of most critical part of the immune system, but when the T cells are active, they usually recruit B cells as well. When we see more of these, and together those are called lymphocytes. When we see more of these lymphocytes, we think that these are the tumors that are more likely to respond to immune therapy. And so we haven't proven that yet, but when we see tumors that have a large number of lymphocytes present and have an immune environment, so like this is kind of this fibrotic immune environment usually has low immune cells. If we see an enriched immune environment, we think that those patients are more likely to respond to immune therapy and more likely to use it. But this is also kind of, we think, going to help us predict likely the patients that respond well to the angiogenesis inhibitors like those. So you can see like relative to colon cancer, appendix. So in this plot here, we're comparing appendix cancer patients to colon cancer patients. You can see that appendix tumors have a much lower proliferation rate relative to colon cancer, but they're much more likely to upregulate angiogenesis factors, which is part of why we think that the bevacizumab, which is a VEGF inhibitor, is an important part of appendix cancer treatment. You can also see here that the more fibrotic the tumor is, the less lymphoid cells you have. There's an inverse relationship between the fraction of fibroblasts and the number of lymphocytes. And so the big question is, how do we change that? How can we kind of change the fibroblasts so that they're not keeping the lymphoid cells out of the tumor? And this is something that we're working. Looking at retrospective data is very useful, but it will only really tell you about drugs that are commonly used. Like if you want to develop new drugs and kind of introduce new drugs into the treatment landscape, you need to get data from somewhere. And so usually that's preclinical models. Before 7 years ago, there really were not. There were a couple of models of appendix cancer, but not very many, and they weren't very widely distributed. And so that's one of the major undertakings that we did, was we wanted to make mouse models of appendix cancer so that we could use the mice to test new drugs. And so we did that, and that's how we demonstrated that this drug paclitaxel, which is a taxane drug, like we talked about earlier, if you inject it directly into the peritoneal space, which is directly into the abdomen, which is where appendix cancer lives, that it's highly active. And so based on these data, we now have a clinical trial open. Actually, we just finished the phase 1 phase and are actively enrolling in the phase 2 phase. The main eligibility criteria is that you have to be possible to do a diagnostic laparoscopy. So if you've had, right now we're excluding patients with prior CRS HIPEC. So this is only patients with de novo metastatic disease who've not had a prior CRS HIPEC at the moment. But hopefully after this initial trial, we will be able to expand our eligibility criteria, because I think there's a lot of promise to the intraperitoneal therapy. And so that kind of brings us to PIPEC. A lot of questions about PIPEC. I have to say, so we actually don't do PIPEC at MD Anderson. PIPEC is a surgical procedure because you have to do a diagnostic laparoscopy where you kind of insufflate or fill the abdomen with pressurized air, and then in that pressurized setting, the aerosolized chemotherapy is added, and that's why it's called PIPEC, pressurized intraperitoneal aerosolized chemotherapy. There are many trials of this going. So this is available already off trial in many centers, but there are now a lot of trials that are open or being opened. Dr. Wagner at the University of Pittsburgh, or sorry, Allegheny Health in Pittsburgh, has a trial, and Mustafa Roof I don't know if his trial is open at City of Hope, but it will be open very shortly, or two. But there are many other sites like New York City, Miami, Dallas that are doing this. I think it's definitely promising. There's data presented at this conference called SOGI, which is Peritoneal Surface Oncology Group International, last October, that looked very positive. But there still have not been a huge number of patients treated, and so this is one of Dr. Roof's papers. You can see that, in 12 patients, the, response rate was roughly 50-50, which is it's not bad because these are, again, these are all patients who've either relapsed after surgery or have had multiple chemotherapy regimens. So 50% response rate is not bad, in this patient population. But, we really need to kind of treat more patients, ideally on trial, to learn what are the tumors that are likely to respond. And the other important thing to remember is that, PIPAC just refers to how you're getting the chemo. A lot of these studies have been done with oxaliplatin, so this one was with oxaliplatin. But Dr. Wagner's study at Allegheny Health is going to use mitomycin. And Dr. Roof's next study may also be mitomycin. So whether you use, mitomycin, oxaliplatin, paclitaxel, the results could very well be different. And so also many of these trials are combining the PIPAC part with systemic chemotherapy in the off weeks. Usually you can only do the PIPAC about once every 6 weeks because you have to surgically access the abdomen. So I think there's a lot of promise to PIPAC, but what's the ideal drug? What's the ideal timing? Should it be combined with systemic therapy? And these are all kind of questions that are needing to be answered. But I think that it is, in the right patient population, I think it is generally safe, and it's going to take work from our surgical colleagues to identify what is the best combination and who's the best patient, to respond to these different drugs. And we're almost done, kind of my part, and we'll move on to the questions. So very excited about immunotherapy, but I think more than anything else, the thing that I'm most excited about in terms of appendix cancer treatment is KRAS inhibitors. And so this is our own data that we presented at ESMO, I guess 2 years ago now, or a year and a half ago. So again, this is not, highlighting the differences between mucinous and colonic type, which are pretty similar to each other, and goblet cell tumors. So you can see that, pancreas cancer is the prototypical KRAS mutant tumor. Like 90+% of pancreas tumors have KRAS mutation. But you can see mucinous appendix cancer almost as high. And that tells you that, KRAS is a critically important gene to mucinous appendix cancer. And you can see that colonic type is also there. And, both of these significantly more tumors are KRAS mutant in appendix cancer relative to colon cancer or lung cancer. Goblet cell is very much an outlier. So there are some KRAS mutant goblet cell tumors, but they are pretty uncommon. Why is this important? There's a huge effort in the pharmaceutical industry, at least 10, maybe 12 or more than that. Pharmaceutical companies are making KRAS inhibitors. This drug, RMC-6236, is likely to get FDA approved in 2026 from Revolution Medicine. This drug is not likely to go on in development, but there are other similar drugs that are moving on. This was from Mirati, who was bought out by BMS, Bristol Myers. These two drugs, so the MRTX is a G12D specific inhibitor, meaning it only inhibits the G12D mutation. RMC-6236 will inhibit any of the G12. Actually, will inhibit, it will be active in any of those tumors. We tested both of them in organoids and then in mice, and you can see that, you don't, unless you take my word for it, but there's a lot less tumor cells after you hit the mouse with the drug versus control. You can see that Ki-67 is a measure of proliferation. You can see that goes way down. After we did some single cell sequencing, and after you treat with the drug, there's very few tumor cells left. And so we're very excited about using KRAS inhibitors in appendix cancer. We are trying to get a industry-sponsored study of any KRAS inhibitor specifically in appendix cancer, and we're in negotiation for that. So we think that will happen within 2026. And then on top of that, we at MD Anderson, we have lots of early phase studies that are tumor agnostic, basically any solid tumor patient. And so whenever possible, we try to put appendix cancer patients onto KRAS inhibitor studies. we've had 6 patients total so far, 6 appendix cancer patients treated with KRAS inhibitors, and so far we've seen biochemical response in every patient. This is kind of one example of from one of my patients. You can see, seventh line. So the said 6 prior different treatments before the KRAS inhibitor, and you can see now that the CA is dropping dramatically. The One of the things that we're working on is that this again why I think the tumor markers are so important is that the size of the tumor on CT doesn't always correlate well with how well the drug is working if the tumor is very mucinous. And so, by some of these patients where they clearly had a benefit and their tumor markers are going way down, if you just went off the scans, it may not, would appear just maybe stable. And so, we're working on better ways to perform and interpret the CT scans, but also alternative ways to measure the response using tumor markers and in some cases ctDNA. Okay, I think that was my last slide. So first, a lot of our research is for the patients, but would not be possible without the patients. So that's our first thanks, but also thanks to the members of our lab, in particular, this guy Ichi does all of our mouse work, hugely talented scientist, and the computational lead is the man on the far right, Shrikat, has done essentially all of our RNA sequencing analysis. Yeah, and with that, I'll turn the mic over to Amanda, and I think you got your own slides, correct? Yeah, okay. And so that took slightly longer than anticipated, but I think we've got
Sorry, I switched
at
the
least 20
slide.
minutes for
I
questions.
switched the slide off of your team, and I apologize for that.
Oh, that's fine.
Yeah,
No
but
worries.
I got it there now.
No
Anyway,
worries.
that was a lot of information. Thank you so much. I think I really understood probably about 40% of it, but the good news is that I will go through it with a fine tooth comb with you and your wonderful assistant and the others that she has referred me to and dissect it for those of us that are challenged with medical terminology. So let's get into the questions. And let me just preface this. We had a lot of questions asked beforehand, and some of them were repeat, so I tried to combine them, and I've tried to put them in categories, cancer, appendix cancer type, and other questions outside of that. You're asking questions in the Q&A, and I'm sorry, I should have not called it chat. I should have said Q&A, but I know I see them coming in, and hoping that we can get to some of them, but if we don't, I promise you I will post the answers to those questions in the very, very near future, hopefully tomorrow with Dr. Shen's help. So first, low-grade appendiceal neoplasms, LAM or PMP. So Dr. Shen, for patients diagnosed with early-stage LAM, such as PTIS, especially when the original pathology was done at a local hospital, how do you help patients understand their true level of risk and decide on the right follow-up or surveillance plan?
Okay, yeah, so it's a great question. LAM, it's kind of an odd thing in that, so the reason it's called, so LAM stands for low-grade appendiceal mucinous neoplasm. And so importantly, it is not a carcinoma, which means it's a pre-cancer. So it's not technically a cancer. What's kind of unusual about it is that, the risk of that coming back as a cancer is low, but it's not zero. So monitoring is important. I would say more often we would see things kind of overcalled, like we see something was called adenocarcinoma that our team would call a lamin. So I think most of them are actually so if something's called a lamin, it's probably a lamin, but it would be important to review that. But we do at least. I would probably recommend imaging for at least on a yearly interval for at least the first couple of years, and then and tumor marker measurement. So, but it's really important that so lamin is a diagnosis, not a stage. So you need to also assess if there is presence of extraperitoneal, or if there's presence of peritoneal mucin that increases risk, or if there's cellular containing deposits already outside of the appendix, then the risk is much higher. And so we just actually published a paper on this with Ashley Somage, the fellow, and Beth Helmick, faculty, kind of describing risk of relapse and lamina. So I would refer you to that. And then, so with Lambert-Eaton, so honestly, in immunohistochemistry, we don't really like to use the term PMP. PMP is a syndrome; it's not a diagnosis. You can have PMP from ovarian cancer, or colon cancer, or gastric cancer, or appendix cancer, and how you should manage it is different. I mean, there are some times that you'll see PMP and it's not clear what the origin was, but most of the time you can't figure it out, and it's usually beneficial to do that. So we don't, there are some cases where you won't know where it started, but usually you do, and usually it's beneficial. Low-grade disease traditionally does not respond very well to chemotherapy, and so that's why usually surgery is a treatment. I showed you in the slides that we've seen activity with the CDK4/6 inhibitors, we've seen activity with immunotherapy, we've seen activity with KRAS inhibitors. So I think in the future, we may move into a neoadjuvant treatment and then resection modality, but that's we're kind of not quite there yet. So that's why a low-grade disease is primarily treated with surgery, is that traditional chemo hasn't been that effective. Whereas high-grade tumors generally are more effective. And if generally it's better to treat, if you're going to do chemotherapy or systemic therapy, it's generally better to do it neoadjuvant than adjuvant. And that's for one, you're more likely to get the treatment because, the complication rate after a CRS HIPEC is significant. And so you might be many months before you could do chemotherapy afterwards. Especially with immune therapy, there's a lot of data from lung cancer, melanoma, that neoadjuvant immune therapy, when the tumor is still present, is more of an antigen is still present, it's more effective than adjuvant. Likely that is true for traditional chemotherapy as well. So our general practice is that we give people, if you think you need systemic therapy, we do all of that before surgery, and then usually finish the surgery with HIPEC, and then that would be it, and then observation.
Okay. Surveillance after CRS
and then surveillance.
HIPEC.
Yeah, so surveillance is directly kind of linked to the risk of relapse, and so I didn't include that it was in the slides, but I didn't really talk about it. For mucinous and colonic tumors, the risk of relapse is highest in the first 2 years, and so the interval scanning is most frequent in the first years, and then we space it out. Goblet cell tumors, oddly enough, can relapse quite late, and so goblet cell, we're kind of moving towards less frequent scanning, but for longer, just because it's not uncommon for goblet cell tumors to relapse 5, 6, 7 years after. 7 years maybe a little bit longer, but 5 years is not unusual for a goblet cell tumor, whereas it would be pretty unusual for mucins.
And the recurrence rate statistics for PMP with right hemi, no HIPEC?
Well, so it depends on what PMP from what type of tumor. So it's not really like PMP is too diverse.
You can assume that everyone here, but we don't know if it's Ham or Lamin, Hammond or Lamin. Right.
Yeah, so like I said, but you can't you really can't answer that question without having an accurate pathological diagnosis.
Yeah, got it. Okay, so let's move on to high grade. Timing of chemotherapy around surgery.
Yeah, so like I said, we don't have there'll probably never be a study that looks, that randomizes people and does a head-to-head comparison of chemo first versus adjuvant. But for the reasons that we mentioned, our practice is generally to do chemo first, then surgery. Sometimes if there's risk of obstruction or patients are very symptomatic, sometimes you have to go to surgery first. But except for those kind of rare instances, we generally do chemo first. But for this reason, we generally discuss all of our patients at a multidisciplinary conference where you have medical oncologists, surgeons, radiologists, pathologists to make that decision. But unless there's a compelling reason to do surgery first, our standard practice for high grade is to go chemo first.
Yeah, and this is a question, I think it's a loaded question because I don't think you know until you start, but like cycles of chemo, like how do you know? How do you decide when it's
Yeah, so that's a
appropriate?
good question. Yeah, so we don't again, without prospective data, it's hard to say. I usually go with just six. I don't. There's reasons for that. Again, this is a colon cancer extrapolation, which is maybe not accurate to appendix cancer, but except for very rare cases, six cycles of FOLFOX was equivalent to 12 in terms of relapse rate in adjuvant setting. Um, if anything, I think appendiceal tumors become resistant to chemotherapy faster than colon cancer because they're more plastic from the transcriptional state. Um, I can't think of a single time where, after 3 months of chemo, we saw additional response in the next 3 months. Um, yeah, honestly, I can't think of a single one. Because normally, like any tumor marker drop or imaging response we get is in the first 3 months, and then, we'll be stable after that. But before surgery, you're trying to get shrink tumor, to facilitate a better surgery. If 3 months of treatment doesn't do that, which is six cycles, I think it's very unlikely that adding more to that is going to get you there. So that's why our practice is to just do 3 months.
And
Again,
let
we
me
don't have prospective data to find that, but that's what we do.
got you. So in this next question, the side effects. I mean, like instead of asking it this way, let's ask it like your patients that are struggling on FOLFOX. When do you tell them like let's try something different? And then are there repercussions?
Yeah, well, FolFox is great for colon. I usually go with FOLFIRI first. For my own patients, with the exception of goblet cell tumors, where I tend to do FOLFOX first. But if people are having neuropathy, I would stop it right away. Like, if you're getting neuropathy from oxaliplatin, it's not gonna, it's very likely to be permanent. So, um, I would stop it
Quickly.
and switch things. Yeah.
Yeah, quickly. I okay, got it. All right, let's go to low grade. Wait, wait. Somehow, oh gosh, I'm going the wrong direction. Sorry.
It's
Ah.
okay.
Okay, goblet cell. ctDNA reliability in goblet cell.
Um, yeah. So, so if the CGA is positive, it's almost certainly a true positive. I mean, we've seen a couple of positive cases that have kind of resolved on their own, but I think that's, you know, sometimes your immune system can kind of eliminate residual disease. I don't think I've ever seen a clear false positive. The problem is the false negative, and so a lot of tumors, if they stay in the abdominal space, the peritoneal space may not cross into the blood. There's this thing called the blood peritoneal border. Some tumors kind of infiltrate across that, and so the tumor DNA can get to the blood, but some don't. Um, and that's true for goblet cell are slightly more likely to be detectable in the blood, but that's partially because goblet cell tumors are almost all high grade. Like I mean, vanishingly few grade one goblet tumors. The goblet cell tumors are almost all grade two or grade three, and the chance that you can detect tumor DNA in the blood is higher in higher grade. The other thing we found is that tumors with p53 mutation, it's more likely that you could detect tumor in the blood. And goblet cell tumors tend to have more p53 mutation relative to non-goblet. Um, Unfortunately, so a positive test is reliable generally, but a negative test is not always. It's not always, unfortunately. So we're working on this other.
Do you have a percentage of what negatives are false?
But the negative predictive value depends on the population cohort. So like if you um, like the rate of false negative is going to depend on what the true positive rate is, and so it depends on what patient population you're looking at.
So if you're extending out, like shortening the time between, scans and such with goblet, but you're extending the time out longer years, more than 10, I'm assuming. Um, are you catching these things 7 years later with ctDNA testing?
Um, Goblet cell more on imaging. We haven't we haven't the Terra testing's only been around for like maybe 3 years, so we don't have any long term we haven't done ctDNA testing 5, 6 years out really on anyone because the testing's only been routine for the last it's only really been routine for the last 3 years, and I guess we
Hmm.
for the patients where we kind of haven't been doing ctDNA testing, we haven't necessarily been starting it several years later. I suppose we could do that, but we haven't. For the most part, we kind of started after surgery and continue it. But for the historical patients that had like surgery like 2021, 2022, we haven't necessarily been adding it.
Okay, I'm going to go to the next question in 1 second, but I have to say this because I just noticed it. My mother-in-law, my mom, and my sister-in-law are in this call, and so I have to give them a shout out. Love you guys. We've got a great support system. Okay, so we've got some smart cookies here in the appendix cancer community. They want your data. Where is it?
But so we're in general we're happy to share our data with any cancer researcher. That I you know I'm and Amanda, I know you're going to talk about Nord, Mike. I'm not super familiar with Nord, and I don't know if there's like a way for us to submit data to them. The Sierra stands for the something epidemiology. I should know that. So like all of our MD Anderson cancer data like goes into SEER. The problem is that like SEER SEER is okay. I mean, it's collects data on lots of cancers, and so it has a huge number of patients. But the other than kind of like this is an appendix cancer diagnosis, it doesn't capture a lot of the other important information like what is the histology, what is the grade, what is the like
Right.
it roughly captures stage, but like to really kind of make the for example, it does not capture what chemotherapy people got. It doesn't capture details about their surgical history necessarily. And it's I think you have to take that data with a grain of salt just because every institution kind of submits the data on their own. And
Right.
we've seen in the data, we basically each cancer center has a tumor registry, and then that tumor registry data gets submitted to SEER. Like when we've compared our chart extractions to our tumor registry, like we found like a lot of issues, honestly. And so that makes me question an aggregate of lots of people's tumor registries just because unfortunately the most tumor registries it's a human like looks at the chart and fills out
Right.
a human who is not a physician looks at a chart and fills out information, and we've seen a lot of
And so to
inaccuracies.
explain this in like layman's terms, like every hospital records this stuff differently, and so they don't have like like MD Anderson does it their way, MSK does it their way, Mercy does it their way, and so on. And so it's difficult to get garnish all the information.
Yeah, and a lot of it's incomplete. So that's the problem with SEER. So I mean, it's definitely
Yeah, it's
it's
better than
better
not
than
doing it.
nothing, but
Yeah.
there are limits, and that's why we've really been
Well,
focused
and
on
so
capturing.
I must ask you because if you don't ask, you will not receive. Who is the best point of contact at MD Anderson if patients and caregivers won't? So,
But that's me. Yeah, unfortunately, we don't
oh,
have
okay, okay.
in a perfect world we would have someone else that would do that, but unfortunately that's me. If you message me and I
Well,
don't reply,
I know how to get in touch with him. So,
respond again. So I try to not miss emails, but it happens. So again, we're happy to share these data. We presented an abstract on this a year and a half ago, and we're in the process of writing a manuscript. Once the manuscript is out, we can publish with that take all the identifying information out and publish the outcomes data so that people can work with it. We're a little bit limited by MD Anderson in terms of how we can't just like put the data out on the web until it's published.
Ah.
For
Don't get me
but like I
started.
said,
I just had this conversation earlier today. I don't want to interrupt you, but we have 1 minute, and so guys, unfortunately, we're not going to get to even all the questions that were pre-asked. Very quickly, I want to say that ACPMP, which is the most amazing organization on the planet. In fact, they were the ones who told me about Dr. Shen's study, and had, that's the reason I reached out to him in regards to my husband. They have partnered with NORD, and they have, it's a very technical thing, a patient registry for appendix specific for appendix cancer. It's going to launch soon. I know the date, but they won't let me tell it. But I promise you, I will let everyone know, and I encourage you to upload all of your data there, and I can help you if you need to, like the pathology, your medical records. They've developed a system that will put it all in the same format, something that research scientists like Dr. Shen can use for research and innovations in the treatment and cures of appendix cancer. I wish that we could continue, but we cannot. But I will work to get the rest of these questions and the ones that are in the chat, the Q&A as well. I'm so sorry, you guys. I wish we had more time, but Dr. Shen has promised he will come back and do this again with us on a regular basis. So I'm shooting for at least a quarter, but I'm really hoping for every 6 weeks. Thank you, Dr. Shen.
Yeah, you're very welcome. Yeah, I'm sorry we didn't get through all the questions. I can, if you kind of consolidate that, we can
Absolutely.
try to,
Yeah, you can count on
answer
that.
and
Yeah,
send post responses.
absolutely.
Awesome. Well, I hope this was informative for people.
So informative. Yeah.
Lot of information. And sorry we kind of went through it quickly, but we are. Yeah, like I said, we try. We learn more about appendix cancer every day, and we're trying to translate that knowledge into better treatments and better outcomes. As fast as we can.
Thank you so much.
Yeah. Thanks, man.
Bye.